Welcome to our Physical Therapy Your Way presentation on pelvic organ prolapse. My goal tonight is to give you just a basic overview of what pelvic organ prolapse is, as well as its treatment in physical therapy and management thereafter. A little bit about me. Before we begin, I got my start as an athletic trainer and sports rehabilitation prior to going back to PT school. I grew up in Michigan and did much of my schooling there, but moved to the DC area in 2017 and have had the ability and privilege to work with and for many skilled clinicians during my time here. I really love outdoor activities. I like to play soccer, so doing my own PT exercises is a big part of my day. um, Early on in PT school, I realized that pelvic health treatment really kind of clicked for me, and it seemed like there was a huge need. So I'm very happy to be able to share a little bit of that clinical knowledge with you in the hopes that I'll be able to present something novel and hopefully helpful. All right, so just a little bit of an introduction into what a prolapse is. A prolapse is defined as the descent of one or more of the vaginal walls to or beyond the hymen with maximum Valsalva or bearing down effort, with the presence either of bothersome characteristic symptoms or of functional or medical compromise due to a prolapse without symptom bother. So the following is basically that is a clinical definition of what pelvic organ prolapse is. Clinical meaning how does it present functionally versus just the physiologic or medical definition. Basically, this definition serves to summarize both the physiologic and the symptom presentation that we'll usually see in the clinic. It's a loss of structural integrity along the vaginal wall. So if you can see my little pointer here, this would be the anterior or front side of the vaginal wall, and this would be the posterior. Here we're looking at the bladder, the uterus, and the rectum. Okay, we've got tailbone and sacrum in the back and pubic bone here in the front, just to orient you. So it's a loss of structural integrity along one or both of those vaginal walls, with the descent either of the bladder, uterus, or the rectum towards the hymen opening here, okay? Although prolapse can be caused by various things, what we'll usually see when assessing the musculoskeletal system is a loss of support of one of three things. Pelvic floor musculature that you'll see pictured here on the left, okay? So this is a inferior view, so almost like you're looking from the bottom up of the pelvis, and you can see everything in pink here is different muscle groups, okay? So the pelvic floor musculature, so either weakness, insufficiency due to tearing, poor coordination, or muscle atrophy. The second way we can get a loss of support is by loss of support along the connective tissue that surrounds the organs. So here I'm highlighting all the fascia and ligamentous tissue that helps to suspend the organs. So if you can see pictured, this is a top-down cross-sectional view of the urinary bladder, the cervix here, and the rectum. So this is a nice kind of horizontal view of what the suspensory connective tissue looks like, holding up all of these organs. And this is called the endopelvic fascia. And the third way is we can essentially see deficits in the coordination of pressure throughout the abdominal pelvic cavity, which I will talk about in a few slides. This often presents with major postural changes, poor mechanics with breathing, and or skeletal changes like the external rotation and widening of the pelvis and the rib cage that occurs during pregnancy and after birth. Now there is a link to a webpage that has a really nice breakdown of the ligamentous and connective tissue support of the pelvic organs. If you would like to reference this, it's on physiopedia.com, and you can just Google the uterine and cervical ligaments. While there are several different types of pelvic organ prolapse, these are the three that we'll most likely see and treat within the clinic. If you'll reference the picture here on the far left, you'll see a rough idea of what kind of normal anatomy looks like. This, of course, is relative. There are many variations to this in real life, but for the purposes of our understanding and orientation of the organs, this will be our baseline. So again, we've got bladder on the left, uterus smack in the middle, and then rectum towards the back of the body. The second picture here is called a cystocele. So this is a prolapse of the bladder as it descends and puts pressure on the portion of the vaginal wall closest to the front of our bodies. So as you can see here, the bladder is pushing into this front or anterior wall of the vaginal canal here. A cystocele is often accompanied by urinary dysfunction, like incontinence. In the third picture, we can see a uterine prolapse. So this is a prolapse that will occur right along the midline, and often you'll be able to see the descent of the cervix in the vaginal canal. In the last picture, we'll see what's called a rectocele. Okay, so this is a prolapse of the rectum, usually occurring down here into basically putting pressure on the posterior or backside vaginal wall. Now, it's important to note that these organs are not actually coming through the vaginal wall. They're just putting pressure against the vaginal wall. So it will be clinically visualized through the vagina. Like an actual disruption in the vaginal wall is a different diagnosis that we won't be covering in today's lecture. I'd like to note just one more type of prolapse that's often seen, and that's called a rectal prolapse. And this is where there is a descent of the rectum actually out of the anus versus a prolapse into the vaginal wall. So as you can see here, we actually have descent of the rectum anally versus the rectum protruding into the vaginal wall. When we're grading a prolapse, we can use a few different techniques. Often in the medical setting, they'll use a measuring system called a POP-Q, during which they'll take kind of a small, thin ruler, and they'll take with a speculum, and they'll take several measurements, including the total length of your vagina, the length of the vaginal opening, both at rest and while you're bearing down, and then they'll kind of calculate using standardized tools. Within the physical therapy clinic, you'll often find that PTs use a method of visualization that assesses both symptoms and descent towards the hymen in order to grade your prolapse. These measurements may be taken in multiple different positions depending on your report of symptoms, but they'll often be used without tools like a speculum and a ruler, merely using a digital exam where we'll visualize the movement and the descent of organs while you're bearing down. So again, we have our quote normal on the left, a stage 1 of, and these are all stages of uterus prolapse, just to orient you. So a stage 1 of uterus prolapse, it will look like the uterus is still in the upper half of the vagina, but there is some descent. Stage 2, the uterus has nearly descended to the opening of the vagina. So usually at this point, I'll be able to pretty much visualize the cervix when someone is lying on their back in an examination position. Stage 3, the uterus will actually protrude out of the hymen. So at this point, people are definitely reporting that they feel a bulge, like they feel something coming out of the vaginal opening. And then a stage 4 would be complete descent of the uterus out of the vagina. Symptoms of prolapse can really vary depending on the type and the stage. So common symptoms that we'll see here are the sensation that something is coming out of the vagina, sensation of pressure or heaviness in the pelvic floor or even the lower abdomen, urinary symptoms, specifically incomplete emptying of the bladder. So like you void all the way and then feel like there's still some urgency to go, or having to tilt the pelvis to void. Frequent urination and also leakage. Bowel symptoms can occur, so the feeling of incomplete emptying of the bowels, or straining. Sexual difficulties and sometimes pain, although pain is not as common. For mild stages, grades 1 or 2, you might experience back pain, that pelvic pressure or heaviness, difficulty controlling urine or stool, and urinary urgency. With a 4th or 3rd degree prolapse, you might experience more along the lines of urinary retention or obstructive voiding. So that basically means that because there's so much descent, there's usually pressure pushing on the urethra or other structures, and you might have to physically reposition yourself in order to void completely. You also might be experiencing post-void dribbling, where you feel that you've completed voiding, but then you go to stand up and you'll leak urine. Incomplete emptying of the bowel or bladder, or have to perform a splinting technique where you apply pressure to the vagina or the pelvic floor in order to be able to go to the bathroom. At this stage 2, we'll also be able to see and palpate a visible prolapse. About 40% of women will experience prolapse within their lifetime, so it's very common. And this is only expected to increase with the rise of the aging population. However, it's important to note that many patients with pelvic organ prolapse will be asymptomatic and never require treatment. Here's a list of risk factors that we might see in someone's history. So pregnancy with vaginal delivery, hysterectomy, multiple births, adhesions or scarring, neurologic conditions, pelvic or abdominal surgeries, which can kind of feed into the adhesions and scarring, as you might expect. Connective tissue disorders, chronic constipation is a big one, chronic cough or sneeze, digestive issues, obesity, repeated heavy lifting, poor core mechanics, hormonal changes that occur with menopause and perimenopause, pelvic cancers, obstetric injuries, age, family history, and lumbosacral instability, meaning muscular instability at the lower lumbar region. Again, none of these factors will doom you to experiencing prolapse, but they could at least be a reason to kind of seek preventative care if you notice that something like this is going on, especially if you have several of these factors. Pelvic organ prolapse can definitely be a scary and discouraging diagnosis. So often the women who I see are kind of at a loss for how to move forward without surgery, and often aren't fully educated by healthcare providers in terms of their options. In truth, early intervention is really key. I always recommend that as soon as you start experiencing any of these symptoms, come in for an assessment. Untreated, these things can often compound, especially if the root cause is something like poor pressure management on top of muscle weakness. Once a prolapse is at a severe grade 3 or 4, it's much more difficult to treat conservatively. But there are many ways to address symptoms with grades 1 through 3. Let me stress, it is always worth trying conservative treatment. I have several patients who have come in with fairly severe prolapse and reports from their doctors that surgery is the only option, but we've been able to kind of help manage their symptoms and get them to the place where they didn't actually feel like they needed surgery. For this reason, it's really prudent to make physical therapy and possibly a vaginal pessary your first course of action. As a side note, and hopefully as a review for many of you, there are direct access laws in all 50 states, meaning you can come to see a physical therapist first without a prescription from a doctor. It's important to acknowledge the emotional impact of this diagnosis and often how paralyzing it can feel to get the ball rolling, especially if you're dealing with other life-changing factors like being a new mom or just having surgery. But just remember, knowledge is power. And despite what our culture likes to tell us, we are not in it alone. So start building a team of people around you who can help kind of translate what your body is telling you. And we'll move into treatment options now. So here's just a little schematic of what the last slide outlined. So we've got our prolapsed uterus over here, okay? And this is often, a cartoon sketch, but often what it will look like when we've got something like a grade 2, 3 prolapse of the uterus. I'll be able to actually visualize the cervix like that. This little guy over here is called a pessary, which I'll talk about in a little bit. And it's essentially an orthotic device that you can insert vaginally in order to suspend and support a prolapse while you're doing activity. Physical therapy can consist of a multitude of different things, pelvic floor exercises, biofeedback therapy, and others. And then certainly, as a last resort, we have the option of surgery. So first things first, assessment. One of the really beautiful things about pelvic floor physical therapy is that you'll often find that we have a good amount of time to devote to an initial assessment. These conditions can be really multifaceted, so a detail-oriented examination is really necessary. I will outline briefly how I go about things, but this will likely translate from therapist to therapist. Expect to share as much of a full history with your therapist as possible. We will often ask you for a comprehensive story, including orthopedic history, birth history, comorbidities, timelines, bowel, bladder, and sexual dysfunction, and anything else that might be pertinent to the case. I will then move into a full body scan, typically including but not limited to assessment of your spine, your hip, and your pelvis, hips, and your pelvis, to check your range of motion, your strength, core activation, breath mechanics, rib and pelvic positioning, and anything else that might kind of coincide with your current condition. For example, a diastasis rectus assessment if someone who is postpartum and had an abdominal separation would be another factor I would look at. After this, we'll move on to an internal pelvic exam, during which I will assess your pelvic floor musculature, so checking for scar tissue, muscle spasm, pain, dermatology. At that point, I can do a visual exam and any changes in muscle tone. Pelvic floor muscle endurance, strength, ability to perform a slow and a fast contraction. Essentially, how efficient is your Kegel? This is where we'll also assess coordination with your breathing, ability to voluntarily change your contraction and engage your deep abdominal muscles, and very importantly, your ability to relax fully. During the internal exam is where we will also assess any prolapse that's happening. Most of our therapists will perform the entire assessment digitally, meaning using a gloved hand. We'll assess both the anterior and the posterior walls of the vagina by having you bear down like you're having a bowel movement, and then visualizing any descent that's happening into the vaginal canal. From there, we'll be able to determine both type and grade of prolapse. So something important that I want to note here is gravity works. So if you are only experiencing symptoms while you are walking, running, standing, or lifting, that should immediately imply to anyone assessing you that if they cannot find dysfunction while you are lying on your back, that you need to be assessed in a standing position or beyond. So just to expand on that, there have been several instances where I've had a patient come in and explain to me that symptoms that are consistent with prolapse. However, they go on to tell me that their gynecologist was unable to find any signs of prolapse at their last pelvic exam, and they were kind of sent away and just encouraged to give it more time and exercise. Now, often it's obvious with a normal pelvic exam while you're lying on your back, but sometimes it's absolutely necessary to assess someone in the position that they are experiencing the most discomfort. So we're going to try our best to simulate whatever you report to us. If you tell me that you only experience symptoms after 10 minutes of carrying your baby in standing, we're going to try and simulate that specific situation and then assess your pelvic floor. There have absolutely been times when I was unable to see any kind of prolapse while the patient was lying down. And then as soon as the patient stood up, it became very obvious. So this is an important thing to account for. If you're being assessed and you have some specifics when, in regard to when you are experiencing symptoms, have your practitioner assess you as closely to that specific environment as possible. After we finish the pelvic exam, we will discuss any findings and make a plan. Okay. So within physical therapy treatment, we have a lot of different options. Most of them will fall under one of these categories: flexibility, strengthening, breath mechanics. So that includes things like hypopressives, and just general breath coordination. Biofeedback, either using tactile means or instrumentation. Body mechanics and ergonomics, and lifestyle is a big one. So there are many factors that we will plan to address once you begin treatment. When it comes to flexibility, it's very important for us to initially work on making sure that you are not holding unbalanced tension anywhere in the lumbopelvic system. Only about 3 to 20% of those who have pelvic organ prolapse will have symptoms. So that helps to kind of inform our expectations. What this tells us is you can have a structural deficit and the descent of a pelvic organ without experiencing symptoms. So our goals in PT are typically not to reverse any structural damage to the area, but rather to work with the muscles and connective tissues, which are malleable, so that we can manage the symptoms and create a little bit of support. While this might seem counterintuitive, assessing the pelvic floor and surrounding muscle tension is imperative. Kegels are often touted as the best exercise, but this is misleading for several reasons. To understand the mechanics of the muscles, we have to kind of understand their purpose. There are different types of muscles in our bodies. The ones we are most familiar with are gross mover muscles. They move a joint, like your bicep. It moves your elbow joint. The second type are proprioceptive muscle groups. So the pelvic floor fits in here, meaning that the pelvic floor will sense what's happening around it in space and then respond accordingly. It doesn't move a joint like a bicep, okay? Other muscles like your diaphragm and your transversus abdominis, which is your deep abdominal muscle, are really similar. So if I want to make my biceps stronger, I move the joint through a range against resistance in its simplest form, because this mimics its function. Therefore, it does not make sense to train the pelvic floor by performing countless Kegels, because although it is prudent to be able to sense and activate those muscles, this is not how the pelvic floor performs functionally. So prior to experiencing incontinence or prolapse, most of us didn't have to go through the day voluntarily contracting our pelvic floors. And that's kind of the goal when you're moving on through rehab, is to, once you kind of get an idea of how to activate the region, you shouldn't have to go through the day voluntarily squeezing all day. Tension in the pelvic floor is very counterproductive for prolapse, and Kegels are not really shown to help in the long run in isolation. Tight and shortened pelvic floor muscles are not strong. They're usually over-fatigued and holding tension that can contribute to increased feelings of heaviness, difficulty voiding, and overall discomfort. Addressing tension and flexibility deficits will typically coincide with light strengthening and the goal of stabilization and activation of your deep core, hip, and thigh musculature. Remember, the pelvic floor is sensing. So if your brain feels like your hips, your thighs, and your core muscles are getting stronger and more able to help stabilize your pelvis, it will naturally reduce tone in the pelvic floor because there's some restoration of balance. Moral of the story here is, if you cannot relax your pelvic floor, you will be unable to contract it. All right. Breath work is another really important facet of our rehabilitation here, specifically coordination. Each closed cavity within our body has a certain amount of pressurization within it. So when I say closed cavity, I'm talking about the cranial cavity here, your thoracic cavity, your abdominal pelvic cavity, abdominal, and then your pelvic cavity here. Okay. This is the basis of what allows our blood to circulate, allows us to breathe, allows us to create pressure so that we can exert force and use the bathroom. Due to its localization within the body, the pelvic cavity down here holds significantly more pressure than others. These pressures are very sensitive to both our voluntary actions, like squatting or lifting something heavy, as well as muscle balance and postures. So let's say you have a nice neutral closed pressure system, and then after having a baby, all of a sudden you have a large widening of the rib cage and a separation of abdominal muscles. Well, now you've just significantly altered the front side of the pressure system here, okay? And now in gravitational postures, the balance of where the organs are pulled is altered based on your change in your center of gravity and the change in your skeletal system. So, restoration of proper breath coordination, rib positioning, abdominal activation, and practicing with functional and ergonomic tasks will be a top priority for you in order to offload the structures that might be weak down in the pelvis. So, on the left here is a really nice schematic of how a normal breath pattern will affect the pressure system inside the abdominal pelvic cavity. Our diaphragm kind of sits like an umbrella here underneath our ribs. So when we take a breath in, there is a negative pressure system that allows our lungs to expand and our diaphragm to descend. This in turn pushes all of our abdominal organs downward and will get a forward and lateral expansion of the belly and the ribs, as well as a downward pressure onto the pelvic floor. These motions are then reversed upon exhalation. So during pregnancy, the skeletal system will experience an outward rotation of the pelvis, so this way, and an expansion of the ribs up to 2 to 3 inches to make room for the growing fetus. This means that over a period of 9 months, your body is changing its shape at the level of the skeleton. Once you have a baby, you will experience a rebound of the soft tissues, but it often takes the bones much longer to return to neutral, and sometimes they never do unless that approximation need is addressed. As a side note, these changes are not limited to pregnancy. I've seen similar skeletal changes in people who have never had children. But often with pregnancy, that is the most concentrated and exponential time that we'll see those skeletal changes. So when your bones are stuck in a rotated position, you are essentially stuck in an inhalation state like we see over here, okay? Even when you're not breathing in. This can not only change the feeling of your breath capacity, but it can then create a relative chronic downward pressure into the pelvic floor, which can worsen or cause prolapse. This kind of altered pressure system, when combined with exercise like lifting, plyometrics, or just regular caregiving tasks, is then putting load through an already lengthened and fatigued pelvic floor. Pessaries, moving on to pessaries. Pessaries are a space-occupying prosthetic device, usually made of medical grade silicone, inserted into the vagina that can be used for prolapse, primarily bladder and uterine prolapse, stress urinary incontinence, a retroverted uterus, and during pregnancy. Although I should note that there is no good research suggesting that it might be good to help with any kind of cervical insufficiency. The best candidates are those with prolapse who require some symptom management but do not desire surgery, and or those who might be poor surgical candidates, meaning that they have complicated comorbidities or they haven't completed childbearing. Pessaries are a really great option for active women, especially those who are comfortable with self-insertion and removal of the device in order to clean. Traditionally, physicians, nurses, and PAs have handled pessary fittings, but it is now within the scope of pelvic PTs, and we've had pretty good success with it here in the clinic so far, especially as PTs can accommodate more frequent follow-ups and more time allocated for pessary training and functional activity testing. So essentially, if you are interested in a pessary and you're a good candidate for it, you'll come in, we'll spend the entire hour doing a pessary fitting, and then we can also plan for follow-up sessions where we can practice using that pessary during the times that you want to use it. So let's say you're a runner, you're having a little bit of stress incontinence while you're running because you have a small cystocele or a bladder prolapse. We can practice with the pessary, and then I can put you through a series of training exercises where we can actually test it out with your functional activities here in the clinic. So here's just a schematic of how it would fit in the body. So pessaries are most effective for bladder and uterine prolapse, as well as stress incontinence. Unfortunately, they have not shown to be very effective for rectal prolapse. It's quite simple to insert. For a circle-shaped pessary like the one pictured, which is also the most common one used, you'll kind of fold it up like a taco and then insert it vaginally. It will automatically reshape and lie horizontally here behind the pubic bone. So the reason why this can be good for, because in this picture, it looks like it's just supporting the uterus, but often this is quite small compared to what it would actually look like in your body. So let's say you have a bladder prolapse. The pressure of the pessary against this front side of the vaginal wall will support the uterus, but it will also support in this direction a cystocele or a bladder prolapse. It can also provide slight pressure along the urethra here. So if someone's just experiencing some stress incontinence, the pessary can also be effective. There are many different types of pessaries, and so you will work with your practitioner to kind of trial and error and find the one that's the right size and the right shape and fit for you. Once inserted, you really should not be able to feel it, similar to a tampon. Some indications and contraindications for pessary use. Indications would certainly be pelvic organ prolapse, bladder or uterine specifically, stress urinary incontinence, and having the adequate mobility to be able to self-insert and remove. Risk factors for a failed fitting include short vaginal length, a very wide vaginal opening, which might indicate that the pelvic bones are still a little bit separated or that there's some muscle atrophy that's not going to allow for the pessary to be supported by the pelvic floor muscles. Discomfort of any kind. We don't want you feeling that pessary or feeling uncomfortable while it's in. Younger age, smoking history, which can affect the blood perfusion in the area, or previous vaginal surgery. Absolute contraindications would include vaginal ulcerations or erosion, fistula, which is the actual disruption or tearing of the vaginal wall, either in towards the urethra or the rectum, which would be a very dangerous situation, or small bowel entrapment. If you are someone who feels like they might be predisposed to pelvic organ prolapse, either throughout pregnancy or postpartum, prevention can be really, really effective. So there are a few ways that you can kind of lean into prevention prior to experiencing symptoms. Biasing workouts that are low to no impact using lighter weights, thoracolumbar, meaning your thorax and your lumbar mobility and hip mobility. Breath work is another big one. These will really help prime your body with deep stability and coordination. If you don't feel confident in your ability to manage pressure within your body, or you already know that you're at risk for a prolapse or have experienced previously, reducing any heavy lifting earlier rather than later can be really helpful. Pregnancy already adds poundage to your body that is increasing your internal pressure, as well as skeletal changes to your center of gravity that can put you at risk. Thirdly, educate yourself. The more you understand the mechanism and the causes of prolapse, the more vigilant you can be with your own body. And often the more gracious you'll be able to be with your own body when you sense that rest is needed instead of having to push through activities. Don't wait to talk to someone if you're feeling unsure about things. And fourth, making sure that you have a really good team of providers to turn to, who will maybe work with your insurance and be able to help you through the experience. It can be really stressful trying to find good providers when you are in the midst of dealing with symptoms, especially if you're dealing with another big life change like we talked about earlier, like being a new mom or just having had surgery or anything like that. Lastly, as pictured, practicing really good toileting habits, avoiding bearing down and straining with both bowel and bladder voiding, using a squatty potty like pictured below in order to kind of get your muscles in the appropriate position to allow for bowel movements. And overall, do your best to just stop rushing. Allow your body to void at its normal pace. Sometimes we get so caught up in the pace of the day that we rush through basic body tasks, and this can also put you at a little bit of risk. We've all been inconvenienced by the urge to use the bathroom, but letting your body void at its own pace can be a really mindful way to prevent further issues. Before I wrap things up, I just wanted to share a few resources that I will often recommend. This is certainly not a comprehensive list, so if anyone would like to share programs, with me via email or something that they've had success with, please do. This can be helpful if you are looking for a self-guided exercise program or just more information. These programs can be especially helpful if you are, for some reason, unable to seek physical therapy treatment or unsure of your progress. This can be a good avenue. Okay. However, I always recommend that if you find something online and you are unsure of how it's going, you're unsure whether or not it's helping, or are not really noticing any progress within a few weeks, to follow up with a PT to kind of establish your baseline and see if any modifications need to be made. Often there are just really individual nuances that can be corrected and that can allow you to continue on your way effectively. So even if you come in for just a few sessions so that we can kind of individualize the program to you, that can be really, really helpful. I also want to make a note that the American Urogynecology Association, AUGS for short, AUGS, if you Google AUGS, American Urogynecologic Society, PDFs. They have some really wonderful informational PDFs that you can look through on pelvic organ prolapse and a slew of other pelvic conditions. I just wanted to list some references, but other than that, thank you so much for tuning in. Hopefully we were able to provide you with some new information. And if you have any further questions, please feel free to call us here at the clinic. Our Lorton phone number is 703-372-5716, and our Alexandria location phone number is 703-924-2650, and we look forward to hearing from you. Thank you so much.